It's a great thing having a national network of local crisis centers. But you want to make sure that whether you're phoning from Duluth or Los Angeles, you're going to get the same kind of quality care. So that's why it was really important for the Lifeline to establish a national set of best practices that could give the best assurance to callers that they're going to get whatever help they need whenever they call from wherever they call from. And the evidence is clear. It's working.
It also creates a safety net for the entire country so that we always know that 24 hours a day, 7 days a week, there's a place that a person can call. When other things might be closed or unavailable, the Lifeline is always there for them.
Hotlines have existed in the United States going back into the 1950s, but they were always very local and not organized into a national network. The advantage of a national network is that any single crisis center can be overwhelmed by calls, or might even go out of existence at times, and the number is lost. Part of the federal role is to assure that there's a number available to all Americans that can be called any time of the day or night, and where you can reach someone who can speak to you about your concerns, your emotional distress. Historically, hotlines were kind of a one-and-done call. That was really the model. And so we kind of consciously set out to see if we can help encourage crisis centers to stay in contact, at least till somebody was able to really make the kind of connections that they needed.
SAMHSA, along with Vibrant Emotional Health, are the overall administrators of the Lifeline Network. A cooperative agreement between the two agencies outlines SAMHSA's role as the funder of the network infrastructure. From paying the phone bills, to helping provide training and quality resources, to connecting local crisis centers across the country to create a network rather than isolated standalone programs. Vibrant Emotional Health, the administrators of the grant, are responsible for managing the Lifeline along with their partners. While SAMHSA funds the administration of the Lifeline, the centers who take the call rely on local funds to staff their services.
We don't pay the crisis centers for the work they do. Our effort rests on the shoulders of these local crisis centers who are working in their communities in the middle of the night, trying to be a beacon of hope, to people in despair.
Every day, the Lifeline receives more than 5,000 calls from people in distress. And because of our crisis centers, we are there to respond to those calls. Suicide costs the United States $51 billion annually, but states can reduce this financial burden. Crisis centers save states critical resources by ensuring callers go through the right door to local services, and reducing burdens on emergency rooms, police, and emergency responders.
Everybody really needs to be involved from the national level to the state level. Having a collaboration between a national suicide prevention lifeline and the local community ensures best practices because the National Suicide Prevention Lifeline has the ability to do research.
I think the biggest impact that the Lifeline policies have had is not only on my center, but at a state level. Our center has had the ability to really kind of push the envelope and really encourage all the crisis lines in our state to use these best practices. Anytime you have access to a tool or to knowledge that is going to impact the lives of people for the better, we need to make sure that that information is spread and that people have access and that we can make sure that we are meeting the needs of our population in the best way that we can.
So I think today, the role of crisis centers has become much more central in crisis care and in overall suicide prevention than it's ever been previously. Because it's the way, at 2 o'clock in the morning, or sometimes even on a Sunday afternoon, if somebody's suicidal, they may only have two options, which is to go to or be taken to or get to an emergency room, or to call a hotline.
The Lifeline is based on the concept that we're trying to de-escalate callers. We're trying to keep them out of hospital rooms. We're trying to keep law enforcement from having to go out, from 911 from having to be called. So that keeps other community resources able to respond to those higher needs. It saves dollars, it saves money.
Emergency department care and law enforcement responses are really expensive. They're also disruptive to people's lives. So when Lifeline centers are using imminent risk policy and they're using sending people to the hospital and calling the police as a last resort, we're really making sure that resources are being used more appropriately, and we're preventing emergency departments from getting clogged up with folks that shouldn't be in the emergency department in the first place.
And the number of those imminent risk calls that we have where we have to intervene with emergency services without the permission of the caller are really such a small amount of calls that we take.
We really need to work in partnership and collaboration with our local law enforcement and 911 call centers. But we really need to work together as a community to ensure that that person got what they needed. So we needed to close that loop.
How do we do the least invasive thing at any given point, reinforce people's dignity and create the best possible structure to avoid things going wrong that are going to stop that person from calling the next time?
Suicide prevention is challenging. It's not easy. It's not something where we can just say, okay, we have the simple formula, do X and Y, and we're going to save lives. It's not that easy. We can't rest on our laurels. We have to constantly be trying to get better at what we're doing. And the crisis centers, to their great credit, have continually worked to improve their own practices, and we have tried to provide the support to them to get better and more effective at what they do, because lives are at stake.